Hello.
The person you have called is speaking to someone else. You can wait or call again later.
Yes, sir. We are live now.
Okay, thank you. So very good evening. Sincere apologies for certain things, certain technicalities which are not in our hand. I, Ankit, on behalf of Alkem2 extend you a warm welcome for today's power-packed panel discussion on overlapping symptoms of BPH and OAB, which are the symptoms of obstruction and storage. This being an exciting and stimulating session because BPH and OAB have always been discussed separately, individually at multiple forums, but very rarely and occasionally together. And this makes it more thrilling and exciting. And I'm sure it's going to be a power-packed panel discussion. As part of our constructive program, we at Alkem2 to reduce the disease burden have always been in the forefront in knowledge sharing and scientific dissemination in the field of urology. It is my honor and privilege to speak about Dr. Sanjay Pandey sir, who is our moderator today and who believed in this need of having the discussion around this topic. Dr. Sanjay Pandey sir is the head of department for andrology and reconstructive urology at Kokilaben Dhirubhai Ambani Hospital, Mumbai. Sir is a powerhouse of energy and is an epitome of determination, sincerity. I know him whenever I've discussed with him, putting in close to 16 to 18 hours a day, completely dedicated towards superior patient care, and especially in this current challenging times. I also take this opportunity to welcome and introduce our panelists, our valuable and esteemed panelists, starting from East, Dr. R.K. Gopalakrishna, Director, Fortis Hospital, Calcutta. We have Dr. Sadashiv Bhole sir, Senior Consultant Urologist, Andrologist and Robotic Surgeon from 7-Star Hospital, Nagpur. We also have amongst us Dr. Mohammad Taif Bendigari from AINU Asian Institute of Nephrology and Urology, Hyderabad. Moving to West, we have Dr. Abhishek Savalya, Consultant Urologist from Ahmedabad. And moving up to the north of the country, we have Dr. Kamal Chelani joining us from Jaipur. So over to Dr. Sanjay Pandey sir, and hold on your seat belts. Thank you so much.
Hi, Ankit.
So, yeah.
Good evening, everybody. This is historic to think out of the box. I gather Ankit and your team have looked into this important aspect, which we are already a part of since many years, treating both the symptoms, looking at patients' bothersomeness while looking at the safety profile of individuals who come to us. So the session one, which is happening today, thank you for the introduction and thank you for giving us an opportunity. Our apologies on starting late. We will keep it crisp and we'll look at sharing our experiences around. So overlapping symptoms of bladder and prostate mounting to huge amount of bothersomeness takes its very insights from a larger picture of LUTs, which has multifactorial, and there are so many aspects that will come into. So we're going to move forward and look at, I carry greetings from Mumbai and from Kokilaben Hospital, where I'm seated in the office after having completed a slightly longer day today. Every life matters and the individuals who come to you do matter. It is important for us to look at quality of life of these individuals who actually change clinic to clinic, hospital to hospital, and individuals, colleagues in fraternity of urology and other practices in their continued problems which they go through. So while I bring you greetings, and I also bring greetings from the dream team that we have at Kokilaben Hospital, the big team which has actually helped us in the last 12 years to take this subject forward in our own experiences. I put forward experiences which colleagues in the esteemed panel today have agreed to take it forward. Thank you, colleagues in the panel. It was so kind of you to have agreed to one single phone call and said, we want to vouch in. I'm sure the session 2 is completely open, which happens on 10th of September. And colleagues could actually just get in and probably agree to come. As I start, let me also pay my respects to seniors in the audience, my teachers, and senior colleagues from the city of Mumbai and from all over the country who have actually joined in. Thank you so much, teachers. I would also request them to actually put their notes around, which we would continue looking at and commenting around, because you all are panelists. I mean, you're all clubbed together today to take it forward to the highest possible level. Friends, while there are winds of change and we have seen wings of change changing around, there's also the subject changing gradually, and therefore we see every year the ICS changes terminologies and makes it forward to the highest possible level of combination. So while there's a global threat and the world is at crossroads, when you see a patient in his 40s to 90s, we also at crossroads between the symptoms of prostate and the bladder, and we blame each other for that. And that's where today's discussion is going to move forward. So taking that forward in real times, just let me tell you that those 5 patients who are going to speak to us today, every patient tells a story. And every doctor lives a passion as a passion in the audience of all teachers and colleagues in the audience. That's the only purpose the doctor and the urologist have. The dedication, inspiration need not be recognized or rewarded, but it's the ultimate sacrifice a doctor does in the most unearthly hours and circumstances. Starting from 8 o'clock early morning, very bothersome patient coming to the outpatient department to the late night emergencies. And while our colleagues, to whom we salute today, are the COVID warriors and doing best, the faith of these 5 patients whom we talk about today, in their faith to the urologists and healthcare will move mountains. And let's take this forward, and I'll wait for all the comments which will come in, which I would put forward and take questions. It'll be good to have this live session move forward. So as changes happen, man, machine, and motivation, and then there are medicines. And the evolution of medicines and the way we have got these medicines move forward, I think it's time that we look forward to these patients. So while our recent understandings of BPH and OAB and the combination of this overlapping and confusing symptoms, which actually take the larger picture when patient comes in, we have, frankly, with evidence, research, and our own ways of learning as we continue to treat, have moved forward to very high levels. So while we change goalposts as we understand and see more, the evolution of these subjects, the evidence that we have today, which will be presented by my colleagues in the panel and audience around, the experience that we have and experience of my teachers, which will come in as comments. I would wait for that as it comes in. And finally, the expectation of these 5 patients as we move forward. I hope to take off this flight safely now with case number 1. 59 years, young male. Increased frequency, urgency, occasional urge incontinence, nocturia. And these are progressive. He narrates satisfactory flow, and let's believe him. No dysuria and no hematuria. He underwent therapy for above symptoms for 4 months with tolterodine, which was given to him in escalating doses as an attempt to bring about the control of his storage symptoms. But it did not find much relief. So the attempt was made from 2 milligrams to 4 milligrams. And then it was given for some time. 2 years ago, in his history of the last 3 years, he actually did take it for a few months, and then he finally found no relief and he stopped it. His symptoms continued to be bothersome, and he then underwent treatment with another colleague with darifenacin 7.5 milligram. I'm sure he must have got some relief, got a partial relief as he stated. The colleague urologist would have taken him to 15 milligrams at some point in time, but possibly he stopped this too. He is living with his life. Dr. Kamal, if you're around and you heard the 59 years colleague of ours speaking all this.
Yes, sir. This young male, 59-year-old, is having more of irritative symptoms of frequency, urgency, and occasional incontinence and nocturia. And I think he says that he has satisfactory flow. But what I do is I always ask him to go for uroflowmetry and ultrasound to show what his flow is. Then only I believe that how his flow is. So I will go for some investigation like uroflowmetry and ultrasound with post-word residue on it.
Thanks, Dr. Kamal. So basically, you have listened to him passionately. The bothersomeness always scores the first point, and that's how the patient would complain first. Other things are actually in an interrogation that we do gradually as we gain confidence of the patient and continue reassuring with questions. We take it forward. So that's fine with us that you have looked at it because he has got so much of symptoms, the symptoms of only one kind which has been there. Do you want to know anything else on this patient beyond this? Apart from doing investigation, you want to know more about him at the age of 59?
Yes,
so
sir. Yeah, I would like to look at the comorbidities, especially if whether he has diabetes or not. If he has diabetes, whether he's serious about it, whether he's regular with his MD, taking regular pills or not. Because it could be an associated finding, and the causes of his symptoms might as well be not due to bladder outlet obstruction, but because of such comorbidities. Other things like backache, lower limb weakness, paresthesia. Basically, to rule out.
Thanks, Abhishek. Yeah, thanks. So I've got it. I've just got leads on what you wanted.
Yeah.
So let me pass that to you.
Okay.
So the other findings which I should have given you, but I just held back for a while, was he underwent TURP 4 years back.
Okay.
Obviously, a colleague who did operate him knew that this man was obstructed and deserved therapies around. His present symptoms, which he complains today, were milder than for the first year after TURP. And in the next 3 years, as you rightly heard from the patient, he had issues which were addressed, but possibly were not to his satisfaction, and he attempted therapies and stopped. So if I go back at this point in time and looking at, this is the picture of diabetes for 11 years, and you rightly pointed out that there could be comorbids around.
Yes.
And Dr. Bole,
yes,
this is what he comes with at this point in time. Dr. Sadashiv, how do we take him forward? He has already seen 2 of your colleagues in urology
yes,
who were attempting their best, and he just jumped the gun and he ran away. And he has got a history of this.
The first thing when such a patient comes, he's quite young. He had a TURP at a young age. That is, he was 55 when he had a TUR. The first important thing is to take this patient into confidence, because he is suffering for a long time.
So
It pays a lot to spend a lot of time with him and counsel him properly regarding his problem, and to tell him that the problem may not lie with the TURP per se, which was done 4 years back, and it might be a bladder problem. Having said that, we have to give him a clear-cut indication and lines on which we are going to treat him, and also the investigation. The important investigations at this point where I will tell him is a basic ultrasound with post-void residue and uroflowmetry. That is the point, and a good counseling is from where I will start in this patient. One important point, Sanjay, which we are missing, though this is just the beginning of discussion, is a 59-year-old man. I always make it a point to ask him his sexual history. That is also very important. Because, so that is one thing which we must address in this young man.
Dr. Sadashiv, actually you did wonders in terms of getting him reassured, because he just jumped gun and he thought everything will happen in a day like paracetamol, which would not have happened. So he had to probably go up the escalating dose because a colleague didn't wanted to take him to the final levels, and somebody may need 1 spoon, somebody may need 5 spoons, and that's how we move forward in our responses. So completely fine with us at this point in time. I'm enjoying this. Dr. Gopal Krishnan, I'll come to you. We examined him. His systemic and local examination were normal, no neurological deficits, which Dr. Abhishek was suspecting. Anal tone normal, grade 1, firm, smooth prostate. He had some reports with him. We looked at that also. He's so bothered. His creat is 2.0, 11 years of diabetes, no hypertension. HbA1c at this point in time is 8.1. His PSA is 3.7. Flat prostate. I think his diabetes is taking a toll and silently creeping in. He has proteinuria and his cultures are sterile.
Yeah. So I think here you have pointed out few things for his bladder overactivity. One, that his diabetes is not very well controlled. So he probably has glycosuria, which is aggravating the problem. Secondly, he has some element of chronic kidney disease, probably stage 3 or 4, with proteinuria. And it is possible that he could be having some element of polyuria with or without nocturnal polyuria.
Perfect.
These would
Would
be factors to look.
Would you like to move forward beyond some examination and some reports? Urologically, you want to like to look at something. So I would just.
Yes, I'd like to look at his uroflowmetry, his voided volume, and his voiding diary. Those are important to see what is his bladder capacity.
So I want to show you this because maybe the uroflowmetry graph is just missing on few of these patients because they are real-time cases we have pulled out. His ultrasound showed bilateral echogenic kidneys, though he claimed his sugar levels done by a pinprick every day looked close to normal, and therefore he became a little erratic on all that. His bladder looks overall normal with no bladder wall thickness kind of picture, which almost sometimes patients are panicked about. The prostate is 27 grams, no medial lobe. It was chopped very well 5 years ago. The bladder volume that he kept on ultrasound was 150 ml. So that is another observer-oriented investigation. He came to the clinic and he did uroflowmetry, and 2 uroflowmetries were 160 and 140 ml reported volumes. These were all real-time cool volumes. They given enough chance to be showing their best flow. Qmax was ranging between 10 to 11 ml per second.
Yeah, the uroflowmetry, the Qmax is rather low. So since he has a history of previous surgery, it would be important to exclude a urethral obstruction in the form of a postoperative stricture or a bladder neck contraction. So if he has no documented UTI, it would be useful to do a calibration in the OPD, which is rather painless, acceptable, and also free. And the patient will be compliant with this.
Got it. So Dr. Sadashiv actually already reassured the patient, and patient has agreed to stay back. We looked at his reports. We gave him a chance of a uroflowmetry, and
Before that, I would like to have a look at the voiding diary also to evaluate his nocturia. Why is that happening? Whether it's nocturnal polyuria, whether the nighttime urine output is more than 33% of the total urine output, then that would mean that he has polyuria because of diabetes. That would come.
Okay. So he's a diabetic. He has got nocturia, which is bothersome, but he is living his days also equally bad. So that's right. That's giving me a good point. Dr. Taif, this gentleman's warding diary was asked by Abhishek, and we got a warding diary. So the warding diary is about his fluid intake. These are all approximate 2.7 liters. That means he drinks well. He's a man who also possibly goes to the gym. Increase daytime frequency 12 to 14 to nighttime 6 to 7 with constant small voided volumes. Again, the same 140 to 170 on his bladder diary, and his urgency, which is significant, which he mentions as at 1+ or 2+. His total urine volume is 2.6 liters, and nocturnal urinary volume is 1 liter. Dr. Taif, you want to just comment on this, which Abhishek had asked?
Yeah, seems to be a pretty high urine output. Nocturnal volume per se does not qualify the 33% cutoff, but still, I think maybe we can do pretty much there some amount of benefit to him, and significant amount of distress in terms of his frequency and nocturia. Yes, I think there are some things which we may need to look in further about his intake of stimulants, caffeine intake, or of those things, where we could probably get in lifestyle modifications and behavioral changes, which could give him some additional benefit along with the pharmacotherapy that we will put him on.
Getting it. Yes. So I heard Dr. Gopal Krishnan talk about this important aspect of calibrating patient. He denies any obstructive warding, but sadly, because of the overactivity which set in approximately a few months to a year later after his surgery, and the last few years have been a little troublesome to him. He has still lived his life and managed himself. Diabetes has been on one corner of his head. He has been looking at that kind of an aspect around. So the issues with this patient are umpteen. Number one is, as Dr. Gopal Krishnan did point out, he is also slipping into a diabetic nephropathy. You look at that. He has got his polydipsia. He has got an overactivity, a nocturnal polyuria kind of picture. 1 liter after 2.6 liters comes out when he goes to sleep and gets up every time he goes to sleep and keeps getting up. But the functional bladder capacity is very small. Dr. Bole, coming to you again, what next do we do to him? Because you have reassured him already. He stayed with you, and you also calibrated him. We are a team right now. We are all 5 of us working in the same department. So we calibrated him, and it looked possibly. So we'll come to that. But you can take him forward on his issue, which is more bothersome.
Yes. One point, though, I would like to make is about cystoscopy. Calibration in OPD is okay. It's quick, it's fast, it's cheap. But many times in a patient who has had previous prosthetic surgery and coming with symptoms which are not elevated by a standard treatment which is given by a colleague, I think this makes a case for a cystoscopy. It's not a big thing to do. And many times when we do cystoscopy in such patients, you find that there is a bladder neck contracture. There are some areas, apical tissues, which can cause this kind of thing. And these are seen on cystoscopies. On top of that, you also get to assess the anatomical capacity of the bladder. And it is our policy to leave the full bladder on, measure the capacity for 2 minutes, which alleviates the symptoms in a quite number of patients immediately. Again, bolstering his trust into your abilities with the patient.
I think his voice is.
So possibly, Dr. Sadashiv, your connections.
Counsel him on the basis of three things. One is the lifestyle modifications. Second is the medications and the complications of the medications which the patient is going to have. And third thing is this.
Completely fine. So as you and Dr. Gopal Krishna thought about, Dr. Tushar Kanti Mandal also thought about the same thing in Kolkata. Thank you, Dr. Mandal, for that comment. So while on one side we did a great TURP in the era of 26 or 22 sheath, we also looked at watching him and probably calibrating. So calibration was one angle and cystoscopy was other angle, and I'm okay with both. We all understand that we have our own limitations on the kind of practices, good practices, the cost factors involved. Or we're looking at from a non-invasive to invasive kind of an approach where patients accept things around. So completely fine, Dr. Mandal, that we need to exclude a post-operative stricture, a bladder neck stenosis, and both Dr. Gopal Krishnan and Dr. Bole decided to look at that aspect also at the very outset, because for some reason around attempts to therapy on his overactive component, which was bothersomeness, was not giving relief. 4-6 weeks of therapy was not really helping out. If we for a while understand that Dr. Gopal Krishnan did a calibration and a 16 French catheter went in very freely. The patient said, I pass urine very well and my residual volumes on the ultrasound are 10 to 15 ml. At this point in time, there's a limitation for him to go to a cystoscopy immediately, and we will go up the ladder. We have promised him that we'll sort him out. He never underwent a calibration, etc. So I think it's good enough. He's happy enough at this point in time. So I heard from you the options. So I gather that if I jump the gun already and look at that there is no significant obstruction on one angle, because I will change the case immediately if it required so. What will be the options of therapy which I would like Dr. Gopal Krishnan to take forward from where Dr. Bole left? So we did a cystoscopy and we did a calibration in this very patient. Take it for granted that there was no major obstruction. So any of these calibration, you felt good enough. 16 French calibration was good enough. And I said, I don't find anything, which Dr. Mandal also commented around. So would you take him forward on the options which he's so bothered about for the last 3 years?
Yes, I think Dr. Bole raised an important point of cystoscopy. I think that has got a paramount importance if this person had any documented UTI or microscopic persistent hematuria. If those are not there, then perhaps I would be happy with a calibration for the time being. Now coming to the therapy, it seems to be here that the urethra is all right and his main problem is with his bladder, which is misbehaving. So yes, all the points that you have raised, behavioral therapy, that is to reduce his fluid intake, control his blood sugar so that he does not have polydipsia. He is intolerant to tolterodine. So perhaps I would add him mirabegron in the highest dose possible. Maybe combine it with tolterodine or solifenacin to reduce the side effects and see how he goes from here. If his blood pressure is well controlled and if he does not have pedal edema, then I may consider giving him desmopressin, but that is at a later stage, not now.
Got it. Anybody of you?
Yes, I would say that his Qmax was a bit low. So I would also add an alpha blocker, just to be a trial of alpha blocker if at all, for at least 1 month. Besides lifestyle modifications and the Kegel's exercise, behavioral therapy, bladder training, and an antimuscarinic. And I noted in the history that he was started with tolterodine 2 milligram, which I believe is not the is a suboptimal dose for such a case, and 4 milligram should be the better option. And he had a relief darifenacin. So and studies have, I believe I have read studies which have shown that tolterodine is a bit inferior compared to solifenacin. They have compared it with solifenacin, and so I would rather start with solifenacin.
Okay, Abhishek, I've got it. Abhishek, I've got the point.
Okay.
He was given 2 milligrams by a urologist to start with only, because he also has a similar apprehension as Dr. Gopal and Dr. Sadashiv had, possibly an obstruction. Start with a small dose. Didn't get relief. He was given 4 milligrams. I did mention on the first slide.
Yes.
Dr. Taif, you wanted to comment.
I was just making a comment that what Dr. Gopal Krishnan said. He has a patient wherein he has tried two antimuscarinic agents, not symptomatic relief with that. Probably due to the side effect profile of these things, it would make really important sense to start off with mirabegron and then add on with solifenacin later on. Alpha blockers, I do not think would play a major role in a patient who has already underwent TURP.
Super. So, friends, actually at this point in time, 12 minutes into this discussion, we have jumped in from 106 to 140 colleagues who have joined in around. I gather there are two aspects to it. One is the patient's bothersomeness, which is progressive, and a colleague urologist who started with a shorter amount of dosage and went on to the full dose and attempt to do it in that time 3 years ago, 2 years ago, to now that we are obviously making him confident and reassured we've got to get results on him. And rightly, as you said, we will attempt therapies that is available around. Let me move forward and see what happens around. Okay, so I have just moved forward on the real time in him. 5 weeks later, he revisits us. He's continuing to still be anxious. And he knows that when he comes to see us in 6 weeks' time, he would carry a warding diary and would do a uroflowmetry kind of thing. So he carries a warding diary, which is 2.1 liters. He has heard you on some behavioral therapy and has given it up. Has become a religiously a Jain and doesn't drink everything in the evening. Total voided volume is 1.7 liter with nocturnal voided volume is 4.2 ml. So he has done that part. His diurnal urgency is still quite significant. He had one episode of urge incontinence. So this is 5 weeks later. You all were very thought processly moving forward in helping him out on ruling out an obstruction before you took the options of therapy. But we decided to give him a chance after a calibration, and he moved forward on a huge amount of behavioral therapy with medical management. So 5 weeks later, which was 3 weeks before his schedule, he comes out of anxiety. He said, I haven't got that, doc. And he was given something, one of the drugs that you wanted to, both of you wanted, mirabegron. So he was given mirabegron at some point in time. Yeah. So any comments on this? I will move forward. Because you did not want to add alpha blocker, Dr. Taif and Abhishek wanted to add alpha blocker while he was having that kind of a flow where calibration did not do good results. His uroflowmetry is still the same. His uroflowmetry has not worsened. Dr. Taif?
Here at this point, he qualifies himself as a recalcitrant patient who is not responding to pharmacotherapy with all our combination therapy. So we will have to evaluate him further with a urodynamic study and see and assess objectively at where he stands for further treatment.
But sir, he has just taken a mirabegron, or has he taken a combination solifenacin with mirabegron?
So he was planned with 50 milligrams mirabegron after a calibration, and he has taken 50 milligrams mirabegron. And they have given him 6 to 8 weeks of hiatus because he called up and said, I'm feeling good on the second week. I know this drug takes a little time to start, and we wanted to continue reassuring him. So he did his own mental warding diary and gave some ideas, and then he moved forward around. So his uroflowmetry is still the same, Dr. Kamal. And I promised him only mirabegron. You want to do something more on him?
He's only on mirabegron. I would like to put him on combination of solifenacin and mirabegron. And the thing which has changed in him is the nocturnal polyuria has reduced a lot. His behavior therapy is working perfectly on him for controlling nocturia and decreasing the nocturnal polyuria. But I think I will start him on solifenacin and mirabegron combination, 50 and 5 milligram.
Got it. So Dr. Gopal, I was just wondering at this point in time, the young man, a combination of 50 and 5. What are the timings? What are the timings? His behavioral therapy has helped him in the nocturia. So what timing is the medication being given now?
I'm not entirely sure, but I guess these take about 2 hours to kick in. So I would give it to him about 2 hours before bedtime to control his nocturia. The other important thing is, which I want to know, is his blood sugar controlled, or is he still having a significant amount of glycosuria? As you know, there are some anti-diabetic medicines which cause glycosuria. So it would be worth discussing with the diabetologist about this aspect as well.
Okay. So maybe a combination therapy and blood sugar control. The controls are good. You can see that he is now focused. He understands the responsibility was on him. He's a part of the entire therapy. Got around. At some point in time with this therapy which is going on, and he continues to still be bothered around, when would you look at giving him a chance? So, I heard there's the word called recalcitrant or refractory overactive bladder.
Can I add something here?
Yeah, please.
Sometimes some of these diabetic guys have got balanoposthitis, which causes irritation, and that also causes some amount of urinary urgency. So it would be worth looking at his penis as well.
Yeah, so examination cannot be missed out. All patients, a urologist actually diagnoses diabetes more by looking at the penis and the prepuce, and comes to say that there's an acquired phimosis, which is a big bother of giving UTIs and all that, whatever refractory issues around. So my thoughts here are, while he is on the combination therapy and continue to be bothered, and he has done his best at this point in time on giving us the bladder diary showing the situation is this. At some point in time, I was wondering, would you consider him for a urodynamic study?
Yes.
Dr. Bole.
I think after 5 weeks of behavioral therapy and a single agent, it all depends on the patient now, really. So if the patient is becoming there's a lot of anxiety and he wants to sometimes, force into getting better, instead of adding a second agent, you can do urodynamic studies. If the patient understands that he might wait for 3 to 4 weeks, then it makes sense to add one more agent like sulfonylurea and see the effect. So sometimes we are really dictated by how the patient feels and how anxious he is to get himself treated.
Yeah. So from a non-invasive to invasive approach is what possibly is logical. I think it's very logical that he has gone through all that. So his urodynamic studies, I don't have the picture here. Cross detrusor overactivity with leak in the filling phase. That is all he has at this point in time. Other than that, we know that we have already calibrated him. We did discuss about the aspect of calibration and cystoscopy that he underwent 4 years ago, and colleagues have did point out. I can see some 8 to 9 comments on a cystoscopy early, because we already 4 years since the PURP, and we know what kind of issues can happen in the urethra, can happen in the prostate. The bladder neck issues completely fine with us. So we have done a calibration cystoscopy. You found gross detrusor instability with leak is what is a urodynamics picture. Maybe in somewhere we'll look at that. So you will move forward on him on any aspect right now. Kamal, you want to come in?
Yeah, one more important thing about cystoscopy is one thing we should not miss: interstitial cystitis on cystoscopy, because we have seen some patients who bring so many files with them with not getting benefit with all the drugs. Then if we go in and we see there is interstitial cystitis and we treat with the drug, and it helps him a lot.
So Kamal, I take that point. When we do a cystoscopy, our eyes see what our mind knows. So our mind needs to expect everything, just not a stenosis and a stricture, but to look at the bladder, which is grossly overactive kind of a picture, which even on urodynamics, after a combination therapy has actually moved on. So we have in our mind all that, because you're actually pointing out to a cystoscopy under general anesthesia. That's what you're pointing at. You're also pointing at that you have a mandate that if you go and see a stricture or a bladder neck stenosis, you would go and correct it. You just not see the beauty of it. So I took your point on that. Those are all important points. So at some point in time, you took him forward and took this subject to such level. So the confusion here is somebody underwent a good surgery. The surgery wise, he is good enough. A calibration and possibly a cystoscopy comes as and when colleagues in urology or the team looks at. We also look at his bothersomeness, because that is what will hold him back to us or back to a urologist. He's been hunting for it, get some treatment, leaves, and possibly have not been gone to the full dose. Attempt to always do a bladder diary and bring him back is a report card that the patient carries. And it's both a subjective and objective measurement of how we are moving forward. To show the report card which the patient brings to him and say you've improved, like the 402 ml of nocturia compared to 1000 ml, which was consistent, is a great way of moving forward. So thank you. Thank you for taking this to such high levels around. Case 2. We're just moving into discussions which will become more aggressive as we move forward. Case 2 is a 68 years male. He has got his own lower urinary tract symptoms, but he has got gross progressive urgency for the last 2 years. He has got diurnal frequency, which is quite significant. So its frequency urgency component are of recent onset, which amount to major part of his lungs. When you do a deep questioning, as you keep talking about the urgency frequency, and you're bothered about the last patient who actually could have developed some obstruction, here could be a new onset issue, a 68 years old male. He says the force and caliber are Dr. Pandit non-bothersome. Please believe me, I'm good enough. So we respect that. He doesn't have any major comorbid factors. That's how it is. Now, with this picture around, he was actually treated elsewhere with anticholinergics with some initial improvement. So the history will just move out in terms of talking that this is what it was with him. He saw a colleague, and because he was so bothered about something and non-bothersome or something, he got his initial therapy and he got initial improvement. So he was happy about it. But then after a while of therapy and escalating therapy, possibly his symptoms worsened. That is what it is. Somebody could take this. I was wondering, Dr. Taif, you want to look at that case? You want to ask any more questions? Are you finding any leads here which is worthy of talking?
Yeah, there are a few things which do not add up in this case. So if a person has been evaluated by another colleague urologist, and I'm sure he would have looked into this so-called non-bothersome symptomatology of obstructive voiding. So if he is actually a case wherein there is absolutely no obstructive component, then he should have actually had benefits with anticholinergics. So his age and these things do not match up properly. So very high chance that in the present era of teleconsultation, maybe it could have been assessed only on the symptomatology and some lapse on his evaluation. So that could be one of the reasons why he has been started only on anticholinergics, nothing of alpha blockers or anything of the prostate aspects, and maybe that is the reason why he is having a worsening.
He had initial good response to anticholinergics, but not the best response he was aiming for. 2 years he has been into progression, into quite a substance of his own trouble. So he had some initial response to anticholinergics, and after that he worsened. So let's move just forward. And Dr. Taif, he presents to outpatient department at 8 o'clock in the morning when it's still dark out here. The OPD is not open. That means he's quite anxious. He doesn't have an appointment. So while I come and change myself and go to the operation theater, I examine him and say, hello, come sit down, let's talk to you. So he tells all that. Whatever he has told and whatever your surmise is wonderful. So he tells all that, and we just quickly examine him. He said, that's fine. We just examine you, that you have come in early in the morning. There's a long day that we can spend together. And we examine him, and then I say, I need to scrub and probably get into a case. Clinically, he's a benign prostate. He's grade 2. And that is how it is. So, Dr. Gopal, my take on this will be the first slide. To you, the first slide, does it give you some leads into initial improvement and then worsening and then my examination? I'm just holding there.
Yeah, clearly this gentleman is in the prostate age group, if I may put it in a broad way.
Yeah, perfect.
He has urgency and urge symptoms. He may have some element of obstruction as well, as the last line of your first slide shows, that his symptoms worsened with anticholinergics. So I think the important thing when he has come to your OPD in first thing in the morning is to get him to do a uroflowmetry. That will give us a wealth of information, and a urine routine or a dipstick of urine.
Perfect. Got it. But so as you demanded, what was happening is he had an ultrasound which he had shown as a teleconsult to a colleague, and the ultrasound showed 25 grams prostate with a PVR of 15 ml. He had another ultrasound 2 years ago which showed a prostate of 20 grams with a PVR of 60 ml. So there were 2 ultrasound reports that he had confessed he showed on teleconsult to a colleague urologist in this lockdown, and that is how it was. So while I went to the OT, I said, take your time and show us your best flow, which is non-bothersome to you. Dr. Bole, you want to tell him something that I just come back to the OT and have a look at the flow.
Yeah, this person is clearly obstructed. There's no doubt about that. And see, post-void residue on ultrasound depends on so many factors, really.
So nice.
At that point of time, many people are able with good musculature, with good abdominal musculature, are able to, void it out, void that volume out in spite of obstruction. Post-void residue is not a sign of only obstruction, it is a sign of detrusor decomposition as well. So here in this uroflowmetry, it becomes very clear. There are 2 points. One in the history that he worsened with the increasing dose of, initially he had some improvement and he worsened with anticholinergics. And second is this, that he has got a poor flow rate and a high post-void residue. I think we are going basically treating a patient with obstruction rather than overactivity here.
I would rather say it's I would agree with you, and the right terminology would be chronic retention, right? And on per abdomen examination, I would expect a non-tender palpable bladder, which would remain so even after the voids. And
he was not, Abhishek, I'll confess, he was not a non-tender palpable bladder. The bladder was not percussible or palpable in the morning at 8 o'clock. I did not have the office ultrasound open at that point in time. But when I came back, he had done a double voiding and his residual volume was significant. Don't forget, he is on a medicine still, which he believes had done good to him. And possibly in this background, we expect that he would worsen around. So, Dr. Taif, with this uroflowmetry, it is still not midday, and we have done a screening uroflowmetry and given him one more chance to prove, which was not bothersome to him, is all bothersome to us for his safety. He's still on day 1. He's not gone home. What do we do to him?
He is right at the verge wherein few more days of his anticholinergic therapy would have precipitated into a full-blown retention. So we need to explain to him that what is not bothersome to him is the major component of his problem. And we have to move him off his anticholinergic medications, explain to him what is the probable pathology that is bothering him. And then we have 2 options of really starting him on medical management straight away and look for the option, or maybe explain to him that he may need catheterization if he does not respond adequately enough, and see how he responds, which option he opts for.
So, Taif, I've taken one view of it. The other view was Dr. Abhishek did feel that his PVR of 20 and 60 ml over the last 2 years worsened because there was an obstruction, and all of us agree to it. So one view is possibly to catheterize him on the day that he has come sitting at the edge and the precipice of a possible obstruction in few days. You want to look at the washout period of the anticholinergics. You want to consider a possible alpha blocker and keep him on a closed tab. Anybody else wants to add on to this? Dr. Bole, you want to add on to?
I am not adding, but I want to make this very systematic for even the postgraduates and our residents.
So nice.
What I do is, I do not believe in ultrasound. Number 1, when the patient comes to me, I have a set protocol of doing certain investigations.
Please go ahead.
If the patient to me with these symptoms, I will raise to his ultrasound, KUB, post-void residue, that is fixed. In addition to all the blood investigation which we do. So we, as a standard, do all CBC, blood sugar, creatinine, PSA, urine routine micro. That is standard. Then what we do is we tell the patient that you go get an ultrasound done, come to the clinic.
Ultrasound. The Bole, you have unstable connection.
Bladder, he comes, does urolometry. Should be protocol. So if you follow a set protocol, you tend not miss some things.
Got it. Completely got it.
This patient is obstructed. I would definitely start him. I would start him on a silodosin as the initial dose. I will not catheterize him on the first visit.
Yeah, I would agree with Dr. Bhole. The line of investigation should be systematic so that we don't miss any point. And I would like to add a point that uroflowmetry machine and a sonography machine, if it's available with us at our urologist disposal, it will help us in arriving at a diagnosis immediately on the first meeting with the patient, so that the quicker we arrive to the diagnosis, the better it is.
Got it. Wonderful. Abhishek sir, got it. So let's just go to this important small aspect before we move forward. Not every urologist may be doing a uroflowmetry in his office. Many times uroflowmetries are referred because not everybody will be acquiring a uroflowmetry in his office. That's one aspect of a practice in our country and abroad too. Number one, uroflowmetry alone will have no meaning unless you do a concomitant post-ward residue.
Yes,
Now,
yes.
yeah, very good. So these points are what we are bringing out. Thank you for bringing out these points. Can I take this point forward to another level, which is, ultrasound is an observer-oriented study. What was the patient, an overfilled bladder at that point in time, waiting outside the ultrasound department, and his post-ward residue? The main crux of the matter is his uroflowmetry. What he does, he could even have a uroflowmetry of 25 ml and be completely obstructed, or may have a high uroflow because his bladder was too full. An overfull bladder is sometimes past 700 ml and still have 150 ml PVR. Does not mean he's obstructed. So many a times ultrasound is a good add-on, non-invasive study which comes as a report, and people do carry a PSN and ultrasound today. Everybody is Google patient across your table. Be remembering that. So you listen to him, you nod your head and look at what is not bothersome and what is bothersome. But then you take your safety profile on day one. So my question to Dr. Bhole and to you were, on day one, you're going to send him home. That is what it was. I confess that it was not a palpable percussible bladder. No, and that's what I did in the morning. And we could see this happening around. So rightly pointed out, obstructed patient looking like possibly would go into trouble. And you have made him aware of it. Nothing more. You woke him up by showing his report card. The report card here is a uroflowmetry. In the other case, the report card was a warding diary, which the patient could understand. So wonderfully done. So you send the patient home on an alpha blocker is what it is.
I would like to beg, at a 300 ml, I would strongly recommend him that he should. I would explain the pathology first, that because of chronic obstruction, the bladder has probably become underactive and it needs a rest of at least 2 to 3 weeks before we can evaluate him further. And for that specific purpose, I would advise catheterization for at least 2 to 3 weeks. Usually the patient accepts if once he knows what the pathology is and what's the line of treatment to be.
Got it. Kamal, you want to come in and give some ideas on this?
Dr. I can hear. Dr. Abhishek said that it is decompensated bladder, but it might be the effect of anticholinergics what he was taking.
Okay, that's true.
So I'm enjoying this as much as 181 audience are also enjoying it.
Right, but
what I would do is
to go into retention once he goes home. So I would recommend, it's not a strong, it's not forced upon the patient, but
what we are discussing about is bothersome symptoms of the patient. Patient is not bothered about his uroflowmetry and his thing.
Can I just come in? I got it. So you are all looking at the safety of a patient. Patient has his own bothersome symptoms. And I think we're sitting across the table to actually balance him and explain to him. Explanation has been done very well. The only issue was he's going home today. He can be even called tomorrow morning and day after tomorrow morning. Silodosin will not take a week to act, number one. Number two, he knows he can do a double warding. He also knows that he possibly has worsened. The worsen means he has decompensated as a result of possible So we have got leads in the history. We also know he is an educated man and he understands it. How many patients would agree for a catheterization or would you are taking a radical step? Or many a times your safety profile is so important. So you have countered that and written as a note that patient advised a catheterization today, agrees to come back tomorrow and day after, starting silodosin today. That's fine. Dr. Pole, your last words on this?
It is very difficult for me to convince the patient whom I have met for half an hour to get catheterized in my clinic and go home and come back after 3 weeks. I won't be able to do it. I just have to give him some time, start him on
what's going on. Yes, be necessary for.
And we can tell him that you might require it later and just leave it at that and see how he responds to silodosin.
So I take all the opinions because I know that's where, we beg to differ, but the difference in us is that we look at the patients with a lot of care and support. So I'm completely enjoying this. So we looked at that. We will not be able to Somebody is in palpable retention, in overflow incontinence kind of thing around, where you can actually show the ultrasound machine showing a palpable and visible and a pregnant bladder. Pregnant bladder can be catheterized easier than a non-percussible bladder kind of thing. And we know that once you have a washout period, maybe you could teach him possibly a double voiding kind of thing, though it will not be great and easy aspect, but he has not learned that. So there are many aspects. So I'm enjoying this. I think the audience is having wonderful kind of, I'm seeing some good comments coming in. Thank you for those comments. So it's all about looking at very important. So yes, so very well said. That's completely right. Dr. Tushar is commenting, and I want to add the comment around. Ultrasound is an important aspect. So because a lot of things which is not visible to us on a uroflowmetry, it's always a non-invasive and an invasive. It's always all that fits the bill of a LUTS is a proper investigation. Completely fine. So at this point in time, that is ultrasound is only 6 months old, which shows a prostate which is small, and he had no bothersomeness. Therefore, because many patients do compare, please don't forget, a patient would say, my neighbor has got 160 grams prostate, and I have got only 40 grams prostate, but the symptoms can be. So I think we're looking at that. That is where the Pandora's box is all about. Dr. Mandal, thank you for that comment around. Friends, just give me a second to move forward on this, because this is a Pandora's box. So what next? How to bring him to his reality? Attempt was to counsel him, to catheterize him, and to possibly look at him in medical management. Call him more frequently in the beginning. Once the residual volume goes down in what kind of therapy you attempted, you will be a happy man. You will not look at a uroflowmetry immediately. Uroflowmetry may dramatically not change. Could be a possibility. So there are so many things around. Rightly, Dr.
The point is, what antimuscarinic he was on. If he was just on a 5 milligram solifenacin, I don't think it would cause a huge post-void residue.
So he was on a 5 milligram solifenacin. The colleague gave him 5 milligram. He had a good improvement. He said, I want more improvement. Yeah. And he was not happy. After 2 weeks, he was given 10 milligram solifenacin when all this happened. Okay. On the 6th day, he landed up in the OPD, which was a Saturday morning. So that was a reality. Okay. So we take him now to a new reality, which is where we want to move forward. Okay. And after 4 weeks of Abhishek giving him Silodocin, he comes back and his flow is exactly the same. So with that flow and with a residue which is very significant, so we had a washout of 4 weeks, which 4 days would have been good enough, but 4 weeks of anticholinergic, 10 milligram solifenacin for 6 days. So that has gone off 4 weeks ago. He has been on Silodocin 8 milligrams at his age. And he comes in around and does a uroflowmetry in the morning. Now he comes at 7:45 in the morning. He said, I will show my best flow, because he's very happy. And by 10:30, the verdict is, can we do a urodynamics and prove to you that your flow is still not good? So at this point in time, Dr. Gopal Krishnan, you are actually looking at it very, very closely. He is only on Silodocin. Dr. Gopal, you would like to come in, and then we will invite more colleagues to come in. So that is his real-time urodynamics on the same day, his third visit.
Yeah, if you see, if I could read the urodynamic report for all our juniors, the first thing is that he has got multiple peaks of irregular detrusor contractions, which means that he has got an overactive bladder. Number 2, his bladder capacity is small. Thirdly, with every spike of detrusor contraction, there is a small leak. So there is detrusor overactivity with incontinence, and each peak of detrusor contraction is more than 100 centimeter water. So he's clearly obstructed. If you go to his voiding phase, it shows that the detrusor contractions are more than 100. So this guy has got a severely obstructed bladder with secondary overactive detrusor and a small capacity bladder at this moment of time.
I would like to add that we cannot comment on the capacity and compliance if asked in the examinations to the PG students, that, if there are leaks during the multiple leaks during the filling phase. So I would say that I cannot comment on the actual capacity, but still, yes, it's a severe phasic detrusor overactivity with a strong detrusor, suggestive of obstructed flow pattern.
Well, got it. So his initial bothersomeness was in the filling phase. That's visible out here. The stark reality is visible to all of us, and I've got great audience comments at this point in time. And finally, so-called non-bothersomeness, even after 4 weeks of Silodocin. And the voiding phase tells all the truth. So I think we are coming to the real reality. Kamal, you want to come in here?
Yeah, this patient is completely obstructed, showing very high pressures in the voiding phase. Then the thing which left with us is to convince the patient for surgery. That is, go ahead for the TURP, prostate surgery.
So this is his visit 3. He has got a 27 grams prostate. So your Dr. Bole, your expectations on this patient?
One thing.
Yeah, Kamal, sorry, you want something?
Sorry, sir. One thing I would like to know about is urethra also, because is there any problem in the urethra? The prostate size is not big, although we tell patient the size does not matter in the prostate. So we need to know about urethra also.
Okay, Dr. Bole.
Size does not matter.
Perfect.
Obstruction matters.
Yes.
And when you put in a scope, many times it happens that you find a stricture which has been missed by everybody, and that becomes evident on table. It happens with all of us. And even with a 25-30 gram prostate also, people have significant obstruction. At this point of time, after giving him a fair trial of sulfenacin and with this urodynamic picture, I will definitely convince him for surgery. There are various ways of doing it. What you do, what you're good at is up to you. Whether you want to do a monopolar TURP, bipolar TURP, only TUIP. So it all depends on what you do. That decision is taken on table. But yes, these people, after, if they don't respond to a beautiful drug, a very potent specific drug like sulfenacin, and they still have these symptoms, then you either convince him for surgery or you lose the patient to somebody else, because he will not go on tagging with you all the way, and you keep on experimenting with him. And we have got hard evidence to prove that he has got poor flow, high detrusor pressures. So this candidate is definitely for surgery.
I got Dr. Bole. Dr. Taif.
This is an amazing patient who's had a complete seesaw kind of a journey. You start him on anticholinergics, he goes into near retention. You take him off anticholinergics, you put him on alpha blockers, he's still badly obstructed and leaking on 50 ml, 60 ml. So he needs for sure surgery, but it has to come with a very big rider, because his brothersomeness has been starting his storage symptoms.
I wanted that. I just wanted that. Please tell me.
Yeah, and that will come to the forefront the minute you relieve his obstruction. He has not been addressed for his primary symptom. So he has to be explained very, very thoroughly that he will continue on his medications for his storage symptoms, and that will persist for long. It will not be going to be a very short course of treatment, and it will have its own staged therapies for it as well.
Completely fine. So the message that you're passing around is very, very important. The patient bothers about the fever, but you are bothered about whether it's a malaria or a pneumonia. So you are more bothered about something which is more deeper. And that's where you went in. You tried therapy, the therapy failed. So you know that if you gave him a spoon of sugar, it's tasting salty to him. There's nothing wrong with the sugar. There's nothing wrong with him. Rightly said. So the first and the most important thing I wanted to ask Dr. Gopalkrishnan, which Dr. Sadashiva already told. Cystoscopy is not an investigation to plan a TURP. Yes or no?
Yes, that's true. You can have other non-invasive and non-operation theater related investigations to arrive at the diagnosis.
Good, I got it. I completely got it. So I think you've taken it to logical conclusion. A man who was so bothered, you actually turned him around by giving him a medicine which showed a bothersomeness. Imagine the other way around, that he had actually no obstruction. So Dr. Taif's point comes to a picture, and that's where we like to dwell a little bit on Dr. Taif's point, which was counseling this patient and an informed consent. In today's era that you want absolute waterproof consent happening around on quality of life issues, it is a malignancy. You could have a different kind of a consent, and the family too understands. Out here, the man comes all the times alone. The 3 times he has come alone. His bothersomeness on frequency, urgency, rightly said, may not go away. You may, at the outset, after removal of catheter, having explained to him, get into the medical management. Dr. Bole, you want to take us forward on this patient? He did a good TUIP, a very good TUIP. He passed wonderfully. On day 1, he was good. On day 2 onwards, he said, you, Dr. Pandey, had told me the frequency will be very high. The frequency is bad. I'm no more incontinent, but it's amounting to incontinence. There is another patient whom you operate and say, you would come back in 2 weeks' time and please cut down your water intake and we'll see what goes on. Don't drink too much at night because you will be the sentry or the guard. Everybody will snore. But him, he will daytime be in the washroom around. So you want to take him on the journey post-operatively, which Dr. Taif has actually taken a consent already. You would still like to treat his bothersomeness now better than what it was.
Of course, of course. I have burned my fingers one on exactly this type of patient.
So nice. Tell me.
I have made a point of explaining this on the OPD paper also when I'm speaking to the patient in the patient's own language, be it Marathi, Hindi, or sometimes English. I write it down in front of the patient so that he also understands.
Yeah.
And the things become, if this patient starts coming back to your OPD, you start, getting anxious yourself if they don't get relief fast. So it has to be very clear-cutly indicated to this patient that he might require treatment for psoriasis symptoms for days to come. And then again, we revert back to the same principles of treating psoriasis symptoms, like we have discussed before. Lifestyle modifications, medications, follow. That is what I would do.
Completely fine. I'm okay with this. I think I really enjoyed this. Thank you so much for telling us that cystoscopy may not be the most diagnostic investigation. That means invading and doing something on the table may not be the best choice, kind of thing around. Dr. Gopal, is there any way you would consider a spinal anesthesia or a general anesthesia? Do you keep some amount of counseling or talking or discussing or allaying his fears, or you would consider general anesthesia in all cases? This patient is so bothered. You would also like to turn around the camera and show him when you operate. I mean, just taking about a modern patient whom you have turned around in 4 weeks. You want to take him into confidence forever, because Dr. Tayyeb's idea was about keeping him completely comfortable in the garner of that. I'm going to operate him. I'm going to take him forward. I treat his bothersomeness too. So is there any way in the operation theater too? Or you would say, no, I am a disciplined man. I will do GA. I will operate. You will have incontinence. I will treat that.
Well, see, all of us have one consensus that this problem is not going to go away immediately after surgery. So I think similar to what I say, the way you describe a urethroplasty as a staged urethroplasty, I call this as a staged treatment. The first stage is TURP. The second stage is the medical treatment. So the moment you tell the patient that this is how the treatment is going to be staged, he understands that this is going to take time. During surgery, I take your point about showing them the operative video. Sometimes it's nice to just sort of take a record and then show them later on, or explain it to them later on when they are in a better frame of mind when they come for the post-operative visit. So that is how I do it.
Okay, I got it. So we're actually swaying between, remember, we have got our colleagues, our juniors, our teachers have joined in around, and my respect to all teachers and seniors who joined in around. The first two cases, you have blown my head with the kind of camaraderie that you have put in both the cases around. So you have actually turned tides on counseling, on diagnosing, on working these patients up and taking it forward. Super. We are enjoying it. But this is a situation where you will counsel him. So I was taking it forward that we have got group practice, we have got individual practices, we work in corporates, we work in medical colleges. It's all about how to turn the tide between medical and surgical. How do we escalate the ladder in terms of his bothersomeness to our safety profile, and that balance is what you're taking. Enjoying this. Thank you so much for this. Can we look at case number 3? Dr. Abhishek, if you are audible and visible, look at a 77 years young male. Everybody is young, at 19. So 77 years young because he's a disciplined IAS officer. He comes in his tuxedo. He comes right dot 8:55 into a room and says, Doc, I've got diurnal frequency, which is hugely bothersome. And it's not for the last 20 years that you tell me I'm old. It is just for the last 9 months that my diurnal frequency has become bothersome. I retired close to 14, 15 years ago, but now I can see my symptoms, which my friends had 15 years ago. I have nocturnal urgency. Remember the word he speaks around, a learned man. I've got nocturnal urgency, sometimes nocturnal urge incontinence, a term I had never heard before. I knew there is nocturia. So I'm coming there. So this is a learned man who walks into your clinic, and you are in that place where people come in so learned, they just take you to task. He was not so bothered until 9 months ago, but 9 months he carried on with frequency and nocturia and nocturnal urgency in his language. But what happened in the lockdown? He had 2 episodes of enuresis in the past month, in the month of July. That's how it happened. Okay. So straight away that he has come in around, you talk to him, you said, thank you for coming. Hope you had your breakfast. You discuss with him. Obviously, you give him that kind of a respect he expects from you. You also examine him. You do that bit of it. Grade 3, benign looking prostate, anal tones, no feculates, etc., etc. He narrates a satisfactory flow in daytime. And I heard Dr. Abhishek tell me Even Dr. Kamal tell me that I will not agree to a patient at 77 that he has a good flow. So that you have kept your eyes open. You believe and nod to him, but at the same time, you have kept your eyes open on this. Completely fine. What are your thoughts on this patient who has just walked in at 8:55 in the morning?
Okay, so I will start from the history. Any patient I examine, I first ask for the comorbidities. I don't progress before asking for the comorbidities because I give it a lot of weightage. I would ask for whether he has diabetes, whether he's on treatment for it. Point number one. Second, then I would evaluate his symptoms. I would evaluate the IPSS score, and here he uses, because he's educated, he uses the term nocturnal urgency and urge incontinence, but it's actually probably nocturia. According to definition of nocturia, it's interruption of sleep by desire to void, which is preceded and followed by sleep. So I would ask him whether his sleep is after sleeping, how many times he has to go and void. That would be the actual nocturia. That is just, I'm completing the history step by step.
Getting it. I'm enjoying this. Still, go ahead.
Thereafter, I would also note other comorbidities like whether he has backache or lower limb weakness, paresthesia, constipation. That takes care of the history, weight loss, sexual history, because he's educated. I will ask for his whether he's sexually active or not, right? So next, about the examination, grade 3 benign. I will look at the anal tone and the focused neurological examination of the patient. Thereafter, with the investigations, I would proceed with the.
I'll hold you back. Okay. I've been recently taught by the USI and by the journal that you should not keep a very busy slide. So I'm keeping all under arms. So it's a lesser amount of information here, but information is correct. You just took me back 22 years ago when I gave my MCH urology. Okay. You answered everything in one single sentence. So I really enjoyed it, and everybody who watched it really enjoyed it. So good enough. Anybody else wants to raise hand and say that you want to add anything here? I think it's a very straightforward thing. A man walks in, he has got bothered. In July, he had 2 aneurysms. There's no way. At least hematuria and aneurysms are 2 things where a man will come to a clinic the next day morning itself, including hematospermia. I just missed out. So hematuria, hematospermia, and aneurysms, they will come in the morning at 8 o'clock before your OPD opens. And obviously, fracture penis and retention, they will come at night, 12 o'clock. So that's fine with us. So as Abhishek rightly pointed out, Abhishek, thank you for taking this forward and reminding me of my younger days. So what next was Abhishek? I'm giving you a little break for your water. Okay. What next, Dr. Taif? We are moving forward on this patient. I'm sure you want all this.
Yes.
Obviously. The next thing, after having a detailed history like Abhishek mentioned and clinical examination, these are the basic investigations that you would order right up. And we wouldn't be surprised that a person who uses such fancy terminologies comes to you with already maintained voiding diary to you in the first visit itself.
Yeah. So rightly said, these are learned people, because Dr. Gopal Krishnan can also say, Dr. Gopal, these are the kind of patients who know something beyond us. They would actually attempt all those before they come beyond Google.
Very true. I'm slightly concerned about the first slide where you say nocturnal enuresis. Now, is this nocturnal incontinence? In which case he probably has some element of chronic retention. So that is something I would be very worried about.
Okay, good enough. So that's a good point. That's a good point. What happens with him is, I have detailed that, but so, as I actually said, I'm now following my school senior and DJUI's erstwhile head, because the way he taught us is less bother slides. So nocturnal urgency is, he gets up when his bladder is good full or fullest full, and before he reaches the toilet, he empties. So in his words, I have got urgency at night. I've got incontinence at night. Obviously, he wakes up when the bladder is too full. But in the daytime, he has adjusted himself to his lifestyle where he says frequency, it's bothersome, but I reach the washroom. So that is all it was in his language. He said, my flow is good, and I believed it. And Dr. Taif said, Dr. Pandey, can you get me a Euroflow? So on the first day when he comes in, at least you would look at examination, Euroflow, and order all those investigations that you wanted to. So he did a Euroflow. He agreed to. He said, Dr. Pandey, you are investigating, interrogating me, so I will do a flow. Give me 2 hours. I'll fill my bladder with my cup of black coffee. And he did that. Dr. Bole, you want to comment on his Euroflow, his age, his discipline, and his truth?
Yes. Water volume is good, 527. Average flow rate is 12.5, 12.4. Residual urine is 10 ml. So I think Yes, we are maybe detrusor overactivity and instability is the main complaint and main bother of this patient, and some degree of obstructions.
We are on day one
Yes.
on a very bothered, disciplined man who has actually chosen you on the internet and said, we want to get treated by you. Dr. Taif, coming back to you. So he lives in Hyderabad and he decided to come in. So please help him out now on day one. We are looking at only day one and bothersomeness on these patients. What will you send him home with and how do you want to counsel him and take him forward?
Yeah, I'm just waiting for the reports of the other investigation. This uroflowmeter looks near perfect with a Qmax of 25, with a voided volume of 527. So definitely we are not looking at something which is obstructing him. So he is actually true that there is no obstruction, which is very much evident in this scenario till now. So,
perfect. So I'll come to the other reports. Dr. Kamal wants to come in, so let him speak in and then I'll come.
Uroflowmetry report, the flow is okay, but there is some element of hesitancy is there. So although he's saying his flow is okay, some obstructive symptom might be there. So ultrasound and other reports we'll wait for and we'll take it further.
For that, he went to the institute. He went to your institute and got the investigations done. A smart man, he had his own warding diary. We explained to him and he got another diary. So that is how it is. His 2 to 3 are now all nocturnal urgency. He has already learned on your first visit that so these came little later. But I still wanted, Dr. Taif, you wanted to send him home on day one. Could you just reassure him and send him home and say, come back with reports in 48 hours?
If at this point I have to send him with a prescription, which he would probably be expecting, with this uroflowmetry, I would not be expecting obstruction to be a major component in him. So,
perfect.
But his grade 3 prostate on examination, his age of 77, I would not be trying with something with an antimuscarinic. I would probably start him with mirabegron of something of that sort, and then see where he proceeds further. So I would not venture much into antimuscarinics. My first choice would be mirabegron.
So my question today to the panel was, on day one, an educated man comes and he's agreeing to, he has chosen you and you will bring him back in few days time for sure. But day one, he wants to go back. He doesn't want to go back at the beautiful handwriting and a letter. He wants a prescription. So agreed that he will go home with mirabegron, Dr. Taif. Dr. Bole, you want to add?
I would always combine with an alpha blocker in this patient with this background. A combination of alpha blocker plus mirabegron. I will not go on to antimuscarinic right now. Mirabegron has a fair deal of safety profile, and that is the prescription I give on day one. I very rarely get patients who are convinced to go home after paying my fees without a prescription, unfortunately.
So it's very difficult for a patient to be told that please come back with a report. He said, I came back for treatment, and you learned doctor have taken me to the highest level of investigation, which will take maybe 5,000, 10,000 rupees more, and then you will probably treat the reports. So treat me. You wanted a report. So I'm just looking at that very important. So I'm really soaked in, I'm immersed actually in the kind of discussions you people have put in. Dr. Kamal,
and as always, I tell Sanjay, lifestyle modification is very important in this patient. If he's intelligent, he's learned man, if he's drinking 5 cups of coffee and then complaining of nocturnal aneurysm and incontinence. So all these things have to be due importance. Yeah.
So day one is a lot of talking and a lot of explaining, a lot of understanding him, because the day 3 when he comes with reports will be a little different from day 1. Kamal, your one sentence on this slide.
I agree with Dr. Bole for combination therapy, but I differ with mirabegron because his bothersome symptoms are so much of nocturnal urge incontinence and all. So I would rather start him on solifenacin and some alpha blocker.
Perfect. So I'm taking it because that's a difference in practice we have, and we're looking at the safety of a man who will knock our doors at midnight if something goes wrong. We are going slow and gentle, and that's where, Abhishek, you remember, on the first case, somebody started with 2 milligram tolterodine, which not many urologists would even think. He was playing safe, not that he was cheating him. He was giving 1 spoon, then he would have given 2 spoons too if required. So this is the way people work in, and I'm enjoying this completely. So Dr. Taif, I'm coming back to you. You wanted your evaluation, and it's back here. So his warding diary day and night is 9 to 10 in the daytime, which he's bothered about. He's now 77. Even if he is in the fittest of his profile of IAS, he's still elderly man. 2 to 3 at night, And of the 2 to 3, once surely is a nocturnal urgency amounting to incontinence still. Ultrasound abdomen shows a 77 grams prostate and upper tract look normal. The PVR is 28 ml, which you found 10 ml on a uroflowmetry. So there is an add-on investigation on ultrasound in uroflowmetry corroborating it. PSA is 3.1, HbA1c is 6.0. You see the urine routine, which is a proper midstream and a clean cat specimen, as you explained to him, but after retracting his pupils and cleaning it. RBCs are 6 to 8, and pus cells are 3 to 4. His culture is sterile. So now he is on day 3. You gave him mirabegron on day 1. He's come back on day 3 or day 4 with all the investigations. So he came at 8:35 in the morning.
I think I would continue with him now with this thing with PVR of 28. The only concerning point here is the relatively large prostate size, but we know from his symptoms that there are no obstructive symptoms. His uroflowmetry shows a non-obstructive pattern. Like Dr. Bole said, yes, behavioral therapy definitely has to be added on. So it would be for me a combination of behavioral therapy and a full dose of mirabegron, and keep a close watch on him as to how he progresses, because he does not show from these investigations at this point of time to have any obstructive symptoms at all. Obstructive component is not there.
Got it. So we believe when he says something right, that he has no obstruction, and rightly the panel, thank you so much on this. That means all looks very good. Dr. Gopal, is there anything you want to add?
I'm slightly concerned about the last line of microscopic hematuria. I would repeat it again. I know that there is no indication for giving a course of antibiotics, but I think I would repeat this again in about 3 or 4 weeks and keep the prospect of a flexible cystoscopy in the back of my mind. You never know, he may have an occult small bladder tumor somewhere.
Good. I'm enjoying this. This is basically the word of caution that you put in with all the reports showing normal. Whatever looks abnormal, you were reading through it and taking it forward. Completely okay with me.
So he may have a small bladder tumor in his trigone, which is causing the urgency, combined with some BPH.
Okay, that's fine. That looks good actually. So his issues are progressive frequency, nocturnal urgency amounting to incontinence, recent enuresis, flow satisfactory, prostate enlarged. Dr. Taif, I'm coming back to you. He did not have enuresis for those 3 days. Just 3 days he did not have enuresis, and you had put him on 50 milligram mirabegron or 25 milligram mirabegron? 50 milligram, yeah. Yes. So with what we look at this point in time, my question to all of you, anybody could raise your hand, is this man is possibly improving on a combination therapy by Dr. Bole or improving on only mirabegron by you? Dr. Bole, your combination was an alpha blocker with mirabegron, is that true?
Yes.
Yeah. Yes. So I'm just trying to take the question in a different direction altogether. This patient is improving on this. 3 to 4 weeks later, Dr. Gopal Krishnan wants to do a urine routine again and look at it, and the man knows how to give a urine sample. He has a retractable prepuce. He will give a proper midstream clean cat specimen after. So we look at that. Now, with all this around, can somebody help me out? He has now a concern because his prostate is 77 grams. Dr. Bole, I'm coming to you. You had planned him only an alpha blocker and a mirabegron. Somewhere in the back of your mind, with a patient who has got microscopic hematuria, is there a role for a dutasteride alone or a combining dutasteride out here? I'm just looking at the evidence and experience.
See, dutasteride alone, I usually don't use, except in very specific situations, which we would discuss. In this patient, I again say that size does not matter. So if the patient is persistently having microscopic hematuria, then of course flexible cystoscopy is the investigation of choice. But just giving dutasteride, we have already seen that is BPH component. I have added alpha blocker only for the fact that he is a 77-year-old man with grade 2, grade 3 prostate coming with 9 months of history. So I am a little bit reluctant to start on a treatment of OAB per se alone. I had a combination therapy. Having said that, I think that just because the size of prostate is big, as a preventive therapy, giving dutasteride is not something which I would do in my practice. I would explain it to him that he needs to be in follow-up. We need to follow his microscopic hematuria, but no, dutasteride just for the sake of size without documented obstruction, I would not do.
Okay, fine. Got it. So, anybody else? Dr. Gopal, I was asking the word dutasteride. I just added it because the man said my prostate is large. it looks like Dr. Pandey, in 10 years' time, you will surely operate me. So, is there any way, Gopal, you want to look into this language he used?
Yeah, if he has persistent microhematuria and a flexible cystoscopy shows normal bladder, but a very sort of vascular congested prostate, then I would add dutasteride.
Okay. So, can I just put a scenario here?
Sir. I would like to add dutasteride, and what I believe is that yes, the flow pattern is normal, but it would might as well be that the bladder is compensating the obstruction and hence providing the normal flow pattern. We don't know exactly what's going on without a UDS, but yes, so I would add an alpha blocker with a 5-alpha reductase inhibitor, asking the patient, explaining, he's an educated man, he wants to know why you have added this pill, why you have added this salt. So I would say alpha blocker is to immediately relax the bladder, the prostatic part, and maybe it would decrease the storage symptoms that you might be having. And the 5-alpha reductase, it has been proven according to certain trials that it reduces the size if taken over 1 year by 20%. And if taken even longer, it would decrease.
Okay. So I've got an inclination to add a dutasteride when you see a very large prostate. So I take it from you. Dr. Bole, you did comment something. I would like to dig deeper into it. Is there any indication of giving dutasteride alone in males?
The indications are basically hematospermia, recurrent hematuria following a TUR. And sometimes pre-operatively in patients who are having very large prostate, in which you are planning large and vascular prostate, you are planning a prostatectomy or surgery. So, except that, I don't think that there is a role of a prophylactic medical therapy based on the patient's prostatic size. I don't think there is a role of dutasteride in that. I will not prescribe that medication. It has got its own side effects. There is loss of libido. Then the PSA interpretation becomes confusing over a bit of time. So I am very clear in this.
Dr. Taif, would you like to comment?
Yeah, we in our Indian practice always complain that our patients are non-compliant. They do not follow our instructions. But here, when we are getting an opportunity, we have a well-educated, disciplined man who watches for his youthfulness at 77. What prevents us from keeping him on the so-called watchful waiting modality of treatment for BPH? So I think he would fit in for a watchful waiting for his obstructive components, which if it is there, will manifest itself. And if he feels that eventually we will operate him at 10 years, so let us cross the bridge when it comes. So if it has 10 years,
10 years would be 87, and maybe he would have serious cardiac issues and he would be unfit for the surgery. You might not.
Fine. So, friends, there are wonderful comments coming from all of you panelists. So thank you so much for being so vocal on that. And that is the way I think India practices and the world practices. We have got difference in opinions. Though we beg to differ, we still belong to the dial U for urology. So we are enjoying it. Completely fine with me. So Dr. Taif, I take that very strongly, very well. Because educated man not showing a component of obstruction on one aspect, Dr. Bole decided to keep him completely floating in 87 without obstruction, treating his bothersomeness on one side. I think we're enjoying it. Dr. Gopal, for the sake of only completing this word dutasteride, which has hit me because dutasteride word came in here. So it's not a combination between any. You want to add a comment on anybody who would require a dutasteride single alone? Is there a patient, Dr. Gopal, can I put it like this? In a hospital where you work in or I work in, patients do walk in also saying that I want to see all my reports normal. They do an yearly health checkup. And the health checkup is where they want to see all the reports normal. A 49 years old man who comes and says, my prostate, Dr. Pandey, has an ultrasound showing 65 grams. I'm only 49. I have not touched the gray line yet. So a patient like that walks into your clinic, referred by the medical officer from the health checkup in Fortis Hospital, Kolkata, and says 65 grams prostate. Please help us out. How will you counsel him and say that I will operate you 20 years later, till that time continue waiting? His uroflow is good, is not obstructed. Is he a case for dutasteride by any chance?
Yeah, that's very well put actually. You see, this is a young guy who's incidentally been found to have an enlarged prostate. We need to discuss very clearly the pros and cons of giving him long-term dutasteride. By long-term, I mean actually it is indefinitely, because he must know that the moment he stops the dutasteride, the problem will again recur. So if he's young, we need to discuss him the loss of libido with dutasteride. So if that is not an option and he is very keen to get on to medical treatment, then only he should be given dutasteride. But otherwise, these things should be very carefully discussed. As we also spoke a few days ago or yesterday, finasteride is an option for some of these middle-aged or sort of mid-50 guys who are maybe losing some hair, who may like to have finasteride with the added benefit of regaining their lost hair. So these are all the things to be discussed. The important thing to be told here that they need to be on this medicine lifelong, and I think that will put off many people.
Yes. So, sir, to summarize it, it's not recommended for a patient who is truly asymptomatic, but we cannot label this guy as an asymptomatic guy, 77-year-old male, though he doesn't have a voiding symptom. But what is the cause of these storage symptoms? It's because of long-standing chronic obstruction causing detrusor hypertrophy and subsequent changes. So, I would say he's a symptomatic patient and he needs to be treated.
No, at this point in time, we have got 220 colleagues. We started with 100 and we've got 220 colleagues with teachers, colleagues and well-wishers in the audience. Our flight took off a little late, so we got little liberty to be landing a little late in a cloudy sky. I've got a comment from Dr. Santosh Kumar in Patna who talks about there could be element of chronic prostatitis, microscopic hematuria. If there's a tenderness on DRE, you would consider on the 4 weeks of antibiotics if you look at that. Possibly many a times this mild prostatitis will not pick up on the urine routine. That point is also well taken, Dr. Santosh. So I think we're getting all the opinions. Thank you for those comments. Ankit, I'm very happy with the comments coming in around. We're enjoying this actually. It's a great way. But we're looking at, my right eye is always on the clock looking at landing at some point. So we go to case number 4, friends. 48 years male. Sorry, I did not know that I will talk about 49 years with Gopal Krishnan on a hypothetical case, but there is a real case here. 48 years male. Progressive obstructive lower tract symptoms over 2 years. He has got something obstructive, 2 years. So at 46 birthday, he decided to get obstructed. But he has got new onset urgency in the past 4 months. He has got terminal straining, which is looking significant. He talks about it. He actually vouches for it before you take the interview on him. He has got no hesitancy. Incomplete evacuation on further questioning into detail. So remember, on day 1, if you have a very young man who walks in, you question him more. You probably continue doing all, but you question him more. Anything else you want to ask him, Dr. Bole? You want to take this?
Yeah, the standard lines of history taking, whether he had any previous intervention, catheterization history. We're looking at a young man with obstructive symptoms, progressive obstructive lutes. The first history should focus on whether he's having a stricture, ureteral stricture. So details of this history, and we should, in every case of lutes and patients who are coming with lower tract symptoms and overactive bladder, we follow a set protocol of history taking. So of course, the history of diabetes, hypertension, comorbid condition, previous any intervention, catheterization, etc., etc. So that gives you a very good, fair idea on history, what we are dealing with.
Super, super. So because you told this, let me just remind myself. There was this patient who had a road traffic accident in his childhood. He at the age of 61 came with obstructive voiding and his prostate was enlarged. Nobody ever took this history of road traffic accident in the whole department, and we took him to the theater to do a prostate surgery, obviously with all the workup done. The stricture was so firm and hard at the level of prostatic urethra, so the proximal bulbar urethra, we decided to abandon the surgery there. We decided not to mess up his urethra, with which he was stable after road traffic accident. Probably the elongation stretch injury of the prostatic urethra, where the fibrosis still stayed. He had a continued adjustment to life for 30 years till he became old. That is hair's grade. He came to a point in time when he was called as a BPH, and prostate surgery was planned because of all obstruction. Had somebody taken that real history, which you did talk about, and all of you dwelled about, road traffic accident in childhood and bleeding per urethra, we would not have done this. So we abandoned the surgery after general anesthesia, looking at what we didn't have a consent. So we need to have watertight consent to get inside. With all the preparation which can still be fooled around, I think this was great. So history taking more so in a young man, because you want to go on the left side of A and right side of Z and look at all that you want to pick in. So we picked up all that we can and you really told him. So you asked all the questions that you wanted. The findings were first time with these complaints. That means 2 years of bothersomeness on the obstruction. He is. But that recent urgency is bothering him more. Remember, it's always a balance between more urgency, more leak that he comes with. No comorbids, as you rightly asked. He's a smoker, obviously. What he does in Mumbai is this. He preemptively voids before leaving for office or leaving for home for his work. because he travels this Western Express Highway, the wonderful lumpy, bumpy road during the long drives. And an overfilling of his bladder reaching the office or reaching home is too much of a trouble to him. He's only 48 years. I mean, he is 3 years younger to me. No incontinence, no bowel issues. I mean, I'm just worried about him. So you want to add something, Dr. Gopal, something you want to add on this history with the previous slide?
Well, he has got a combination of obstructive and storage symptoms, as we can see. Smoking may be aggravating these complaints. So I think he needs the next level of basic investigations before we start him on any treatment.
Yeah. So he came with obviously urgency, and he told all that. He actually told his history better than we could have asked him. He has adjusted himself in life on the obstruction by avoiding as much as he can, push, etc. And then I said what he told to us is what was visible. So he rightly said, on day one, you assure him and say, we'll get you sorted. But you have a long history, 2 years of issues that you had. And as a result of which, one needs to look into that. Go ahead, Dr. Pole.
There is no replacement to good basic physical examination, which our teachers have taught us over many years and which they have learned over many years. So this patient, even before ordering uroflowmetry, should have a very good checkup. You should also check his prepuce, meatus, BXO, meatus stenosis. So common in our population.
Perfect.
And these should be very well documented in a systematic way. If we become systematic in documenting our facts and following a set protocol of history and clinical examination, most of the things are not missed. And then, of course, this evaluation which you are talking about.
Completely fine. Got it. So you do everything. You evaluate him thoroughly well. You look at more history while you see under the undergarments. You want to really be happy that everything is fine. Because many men, right from the hygiene you talked about, live with occlusive phimosis and live with all that you can't imagine. You rightly said. So we looked at that. We are just hurrying through. Our flight may land any minute. So let's start talking about it. So that was the kind of thing. Because his history did talk about him adjusting to obstructive voiding at the age of 46. I'm coming to you. We are looking at that kind of an aspect. Can I show you the uroflowmetry? Sorry, I don't have a graph. The graph is a prolonged bell-shaped curve. His Qmax is 13. Is a prolonged bell-shaped curve. His post-void residue is 20 ml, 22 ml. That's what it is. It's not showing the picture here. So prolonged with obstructive curve. You also wanted some more investigation, so I'm just pushing it forward and looking at his ultrasound abdomen pelvis. Maybe one picture is good enough. You want to read this?
Yes, he has a significantly large obstructing median lobe.
Okay.
Hello?
Okay.
Can you hear me?
Yeah, I can hear you completely. Please help him out.
Yeah, so here we have a 48-year-old man with significant symptoms, both obstructive irritative, with a prostate with a median lobe which is abetting and obstructing. So the rest of the bladder looks fine. It's a partially filled bladder.
Yeah. So that is what it is. His other investigations are normal enough. Okay. So very classically at the age of 48, he has adjusted himself to life and he's managing himself. That urgency, frequency, etc. has actually brought him here. Some evaluation is showing him that he is landing somewhere. Please help him out, Dr. Bole. You take it forward.
Yes. So in this gentleman, I have to explain him the need for treatment with medications first. And since he's quite young, I would definitely start him on an alpha blocker. My choice of alpha blocker in such patients is alfuzosin. I start with alfuzosin first. I do not give him an option or even an idea about surgery on day one, even though there is a median lobe, because just the mere presence of median lobe does not indicate surgery. First, we try out the medical management completely, and then only we will discuss the surgical option with him. So my policy in these young men is to start with alfuzosin 10 milligram at bedtime, and some modifications regarding his water intake and behavioral therapy. And I call him after a follow-up after 4 weeks. And then I reevaluate him again.
Completely fine. I got it. So you saw an image which is bothersome and his symptoms also bothersome. So obstruction is visible on the first uroflowmetry. Can I ask anybody, can anybody answer why alfuzosin only at night? Is it possible to give me alfuzosin in the morning at breakfast? I'm just trying to bite into some codes that we have conducted ourselves. Our codes of conduct is before you go to sleep, take an alfuzosin, get up at night 2 o'clock, have a fall and have an injury and a head injury. Is the other way around? Can a patient take alfuzosin in the morning? Dr. Taif, is there a possibility of giving alpha blockers in the morning?
There is a possibility. The only concern what we have is the first dose hypotension thing and the orthostatic hypotension. So if a person is fairly well enough informed as to that complication, that side effect, mostly after the first dose and in the first month of treatment, there is nothing much of a difference that prevents from a morning dose. So in a young fellow who is on the other side, least expected to have an orthostatic hypotension and a fall, fair enough, we can give her, if he wants at all in the morning, can be given.
So nice, so nice.
I would like to add certain points that for silodosin, I would say that we can give it in at any time, because I don't think orthostatic hypotension is a problem with silodosin, right? So silodosin I would give at any time, and I also, if I correct me if I'm wrong, that there are newer formulations which are sustained release, and they make sure that there's no.
Okay, fine. I was trying to bite into the brains. Don't worry about it. Yes. So completely fine. You will choose it. I'm just trying to rake you up. Nothing else. Yes. Dr. Kamal, your last point on this.
Yeah, in fact, some patients, they believe that we have so many medicines in the night to take. Can we take it in the morning? So yes, he can take in the morning. There is no problem. So far, there is no hypotension.
Super. I got it. So I'm very much in sync with what you and our colleagues also are. We've got 222 people on board at this point in time. Dr. Gopal, this patient got alfuzosin with Dr. Bole. He decided to go on a vacation to Kolkata to see his relatives and landed up with you. After 8 weeks of alfuzosin, he did a uroflowmetry at your place. And the flowmetry was exactly similar to what Dr. Bole had shown, a prolonged curve with a Qmax now from 11 to 13. His post-word residue is 22 ml. After 8 weeks of alfuzosin.
Yeah. Two things about alfuzosin. This is something that my teacher taught me. I would always, for these young guys, I would always tell them to start these alpha blockers over a weekend and tell them to spend the next 2 days at home. I would tell them not to drive a car for the next 2 days. So this is a precaution I would always give these people. That's number one. Number two is that this is a young guy, so we should also inquire him about possible sexual dysfunction accompanying this BPH. So
Dr. Bole did that. Yeah, got it. Completely got it. Your concerns are taken. Dr. Bole did that when he did that. And therefore he gave alfuzosin to continue his activities till he gets less younger or older. So your problem is he landed at your doorstep because he has come to come to Kolkata, and he landed up with a flowmetry after 8 weeks of alfuzosin, which has not given him a great relief. All the more learned man, he did check his uroflowmetry combined from Maharashtra to West Bengal, and then the ultrasound is visible to you. After 8 weeks of therapy, you want to help him out?
Yeah, there has not been much improvement in the uroflow except from 11 to 13 ml per second. Since this is a young man, I would not push him for surgery. If he is happy with Dr. Bhole's treatment, then I would, and if his residuals are not very high and his urgency is controlled, I would allow him to continue with the same.
And send him back to Dr. Bhole. That's wonderful. I like that. So that's good enough. Would you give him another option? In terms of Dr. Gopal, I have been given the best medicine for a young man for 8 weeks.
So,
is there a possibility of me getting some better drug? Is there a possibility of me getting not only treated but cured? Can you cure me, please? My father did not have prostate surgery or prostate medicine. He is now 74 and I am only 48 and I am living with all this, and please tell me how long I have to take. 8 weeks and the flow not improve. One tablet of paracetamol, my fever goes away. So Dr. Gopal, you want to look at his complaint now?
Yes, we all know that the 5-alpha reductase inhibitors do not work on middle lobe enlargement.
Yeah.
So certainly that is not going to help him here. Here the mainstay remains alpha blockers. Between all the alpha blockers, there is really not much difference in terms of efficacy. It is only in terms of the side effects. So I think there isn't much more that I can add to this guy apart what he's already on.
Wonderful. Dr. Taif, anything that you want to add? Are you okay?
See, we know that with such a large median lobe, our medical therapy is just buying time till he gets convinced that he needs a surgery. So maybe during that bridge of time, we can add him tadalafil or PDE5 inhibitors, give him a trial of so-called a combination therapy, excluding 5-alpha reductase inhibitors. Maybe that could be one thing, taking his young age into consideration.
I'm taking that. That's great. Dr. Bole, anything, the last words from you on this?
We have seen a large number of patients who do not respond to one type of alpha blocker, respond very favorably to another type.
Yeah.
So this is very much evident in clinical practice. So we still have silodosin with us. The only thing is that it is basically going to give him retrograde ejaculation.
Yeah.
So we can try that before. We are basically preparing ourselves and basically trying to see that we can avoid surgery in this young man, 48 years old.
Got it. So while you all were counseling and avoiding and letting him earn his surgery, and he was not happy with being given silodosin, he said, I wanted a cure. He heard the sentence, he wanted a cure. He went to Abhishek and Abhishek did this urodynamics on him.
Okay.
And he got more convinced because he wanted a cure and he's only 48. So Abhishek.
Yes, sir. You can see in the filling phase, it's extremely unstable with lot of IDCs, involuntary detrusor contractions.
So that is his new urgency of recent onset.
So I was going to add in the last point that he had an urgency, and should we add antimuscarinics along with the alpha blockers in that patient? In this.
So now, please hold on. Wonderful. I just want to break this case here. So this patient was having gross urgency, which was bothersome to him. His flow was only 11. Dr. Bole, in 2 months of the world's best alfuzosin, made it 13. He has not worsened. He has been stable. His urgency may not have improved dramatically, but giving a antimuscarinic or a beta-3 agonist would have worsened him, like the first case, where a second case where anticholinergics worsened a patient. Dr. Bole, would you have looked at any way treating his bothersomeness rather than looking at your safety profile on this patient?
No, I think after a trial of 8 weeks of alpha blocker, if the patient is not worsening but not showing improvement and not happy, it makes sense to add antimuscarinic or a mirabagrone. I don't think there is any significant contraindication to use that drug. We have to make the patient comfortable. Ultimately, the symptomatic relief
very much
looking at him.
Very much. Got it. So you're going to make him comfortable. You let him earn his surgery. At some point, you will also convince him that he deserves a cure. So all the ball is in his court. That's what it looks like, and that's completely okay with us. Friends, we are a little short on time. Pardon me for that. So managing him rightly, as you said, his bothersomeness is very important. We're looking at his age and young man, and therefore giving him that free run on medication, but keeping him cautious. These issues of obstruction are visible to us on a prolonged flow. Safety thoughts of a urologist is very much, but at the same time, you fall in line and give him his relief on urgency frequency by mirabagrone, which only affects the storage phase and not the voiding phase. Long-term therapy is balancing with cure is also in his hand. So I think we like that. We like that idea of taking it forward. Case 5, Dr. Gopal, I'm coming to you. 69 years male. That's the last case, friends. We are just coming to a close in 7 to 9 minutes. Give us that time, because the panelists have done a wonderful job being impromptu. 69 years young male. Gross urgency in daytime. What have I mentioned beyond that? The slide. Occasionally amounts to incontinence. Denies obstructive voiding, nocturia 3 to 4 times. Bothersome voiding diary with episodes of leak. I'm actually putting all in a slide. So I'm conglomerating the case for you. Attempted antimuscarinics, and as rightly said by urologists, you could change antimuscarinics and possibly get better in that era when we had only antimuscarinics and we had no other choices but to change from one to other, go from a small dose to a full dose. His uroflowmetry is good. Take it from me, his uroflowmetry is 20/25. His ultrasound is a 20 grams prostate, his PSA is 1.9. So basically, urgency, occasional incontinence, no obstructive voiding, proven on a good uroflowmetry. No worries about him touching 70 with malignancy. And antimuscarinics have been attempted and changed. But his voiding diary and him, the voiding diary is a result of a gift from the previous urologist who has attempted that. And all looks okay, but he is bothered. So let's look at his bothersomeness, which is our overlapping issue. Thoughts on helping him, Dr. Gopal?
Yes, there are 2 thoughts here. Number 1 is, does he have any UTI? Number 2, does he have any microhematuria? And number 3, is he recent onset diabetic? If these 3, because this is all
normal. These 3 are normal to you.
Yes, these 3 are the 3 thoughts in my mind.
All 3 are normal.
These are all 3 are normal. Then he has not responded to antimuscarinics, so I will probably add a combination of antimuscarinic with beta-3 agonist.
Oh. Yes, I said his flow is good and you believed it. The flow was good. Completely fine with us. So adding
bladder capacity is small. Yes.
Yeah. So that's again related to his gross frequency urgency kind of structure. So I think that's fine with us. At this point in time, Dr. Gopal, the question arises is you added him on a Mira background. What dose you gave him?
I would give him 50 milligram once daily, along with 5 milligram of solifenacin once daily.
Expecting a relief kind of thing around. So I think we are looking at that kind of a patient who has a great profile and is stable enough. Kamal, you want to add something?
Yeah, it has been taught to us during our training that at the age of 69, we should not start this antimuscarinics and beta-3 agonist alone. We should start it with some alpha blockers also. I would like to add alpha blocker also to it.
Okay, so I will take your point. You were a respected panelist. His flow was very good, and other 4 people were convinced that they would only be giving him a combination therapy. So that's completely fine with me. I understand that you have a worry on him. His prostate is only 20 grams. The flow is good, and he says so, and we have proven it here. So that is one take to prevent him.
Yeah.
Your worry is that he, in 2 medicines that you give him on his bothersomeness, he may go into trouble. Let me now tell you here at this point in time, he was given antimuscarinics with a lot of planning. He was having a warding diary. He was looking at, not that he was very unhappy, Dr. Gopal, with his antimuscarinics on his control levels, but not the best on both conditions. So one condition was that his control was not coming well. We went to the full dose. The respected colleague went to the full dose, and the patient was okay, but he had other bothersomeness. So that's where at the age of 69, he could also be on a kind of situation which brings about trouble to him. While the medicine gives a good relief to some level, that is what he wants. Could there be a possibility of some kind of anticholinergic side effect which could have actually troubled him? I'm just coming to that one.
Yeah, I completely agree with Kamal. Sometimes the uroflowmetry does not give us the full picture. And if someone of this BPH age group does not respond to anticholinergics with antimuscarinics, it is useful to add an alpha blocker as a trial to see if they improve.
Got it. Completely got it. So he was on antimuscarinics, mirabegrone and solifenacin for 4 weeks. He came back. His warding diary was very similar, but he was less on the bothersomeness. 8 weeks later, he came back on the same therapy. He was just given continue same. 8 weeks later, he said, I'm not enjoying it so much. So he has already spent 2 months on this, your best possible therapy at this point in time. Dr. Bole, we are somewhere moving forward and wanted to know that, is there any way you can help him out? 8 weeks of therapy on the combination therapy. His uroflow maintains same, but his bothersomeness has not gone.
Yeah, are we looking at a patient who is now refractory to treatment and is not responding, basically?
So would you wait longer, or this is good enough? You said now I agree that you're not responded, or please wait, change your timing.
Adequate. 8 weeks is adequate. I think we have to move to the next one.
Got it. So with available therapies that it was, just trying to show you the filling phase.
Yes.
There's a filling phase which I have here. The warding phase could not be completed for the sake that sadly he passed motions during the warding phase. So his filling phase itself was talking about, you want to look at his filling phase 8 weeks after your combination therapy?
Sir, I would like to add a point that considering a small prostate, we need to rule out other causes of his storage symptoms, like maybe a spinal disease or surgery, or maybe, though less frequently seen in our OPD, but CNS disorders like Parkinsonism or something else.
Absolutely.
Yeah.
Absolutely. So a lot of that will be also told on his progression, a lot of on the clinical history, which Dr. Bole did comment on. A lot of that will come into a clinical examination, which you will do. Any kind of doubts of a refractory obstipation, the way he walks into your clinic, the interview that we have with relatives, all those already gives all that example around. So get into anything which could be an MRI spine or a CT brain may not be warranted till you actually get into that picture. So he is a stable man, walks with his wife to the clinic. He spends time, he does uroflowmetry. He agreed for a urodynamics because I said we could not get a result in you in 8 weeks of having panel told me to give you good therapy, but it did not work. So you want to help him out now, or because you're worried about a 20 grams prostate and continued alpha blockers, or you would say continue this medication?
So he defecates on voiding. That is a dangerous sign. Maybe his anal.
No. He defecated during, and it's not uncommon.
Uh-huh.
So there are one episode of defecating during a urodynamics is unfortunately a phenomena where urodynamics machine closes down. It was only to bring things little lighter for us, in a lighter vein for us. But frankly, he does not have that kind of an issue. So you raise a point, and I take it on face value.
Oh, okay. So he's on combination therapy. I understand 5 milligram with 50 milligram of mirabegron, right?
Yeah.
Okay. So yes, definitely, if he's not happy, then yes, we have to go to the next level. We have to explain, and it's taken for granted that we have also added all the lifestyle modifications, behavioral therapy, Kegels exercise, and bladder training. If all this is not working, yes, of course, we have to go to the next level, and that is probably cystoscopy and Botox. There are multiple options. We need to consider it in detail. Looking.
And can you, in one sentence, Dr. Kamal, give me an answer for this patient at 8 weeks, and Dr. Gopal will come after that. One sentence each to help out this patient. How can I go?
For Botox, I would say there are other things to do. Posterior tibial nerve stimulation and all can be tried in this patient who is not improving on full doses of antimuscarinics and beta-3 agonists.
Okay. Dr. Gopal, can you just wrap up this for your case?
Yes, I think I completely agree. Cystoscopy is due on this elderly gentleman to assess his bladder and to see what else could be there causing this irritative symptoms and this small capacity bladder. So I would certainly go ahead with the cystoscopy before anything else.
Completely fine. So you would keep cystoscopy as an only option to start with. He goes under general anesthesia, undergoes a cystoscopy, and you will come out, or you will take a blanket consent of movement forward on this.
I would do a flexible cystoscopy, but bring him to the theater fasted.
Sure. So I understand the concern. There are a few things which is a cystoscopy is something which should have a threshold. You cannot keep waiting for a quality of life disease and continue treating him. We live in a country where there is genitourinary tuberculosis. Somewhere way in the mind, in the early cases, you thought of interstitial cystitis also. So while you are treating him and he's doing well, he may jump the gun and possibly see colleagues. Not because there is any issue about your therapy. You are moving up the ladder as it was taught around. And rightly, Dr. Akash from Bhopal, thank you for coming in at this point in time. I would also look at Dr. Bole, your experience on botulinum toxin in a patient of this kind.
No, I have very limited experience. You have the maximum experience, so you should tell us about your experience.
Yes.
We learned how to do it from you.
Yeah.
So no, it's not me, but I'll just get forward because this case was treated here. So we convinced him to continue this and come back in again 4 weeks' time. It was very difficult to convince, but he was convinced. We added an alpha blocker as was told by Dr. Kamal, and we agreed to add an alpha blocker. We added alpha blocker. 4 weeks later, he came back with a warding diary and with bothersomeness. So we looked at the bothersomeness score, not in him. We looked at his partner. We looked at his wife and looked at the entire issue. We understood that his agony is best picked up with him leaving the table and going to the washroom during dinner and lunch. Him probably being more irritable with medicines being continued, going to the doctors and having seen few before. So we gave him botulinum toxin 100 units. He is on a follow-up at this point in time, and he is stable enough. We did not initially take away his combination therapy, which should have been done. I was wary about the results in such a patient who was grossly. We are reading between lines, but I'm not sure how these patients will shape up in 2 or 5 years' time around. But his antimuscarinics were taken away. Dr. Mandal, I looked at that. So Dr. Gopal Krishnan's idea of doing a flexible cystoscopy was to rule out everything, which includes out a stricture, a tuberculosis, everything. Dr. Mandal did talk about that. So in a country like India, we will not miss out by going with invasive therapy and putting a label to him as a Botox therapy for future, unless we have done all that we wanted to do. He's not a smoker. We went in around and looked at what it is. So overall, the picture was very clear. Friends, I think we're coming to a close. It's time to land. I've got few questions quickly to start with. That we are today looking at young men to teenage men, even very elderly men. My question to you, Dr. Bole, which everybody will take in 2 short sentences. What is your idea about, or what is the way you do a polypharmacy or a polytherapy for LUTs in a 45 to 55-year-old man who comes with a combination of all these symptoms?
Yeah, we have to use polytherapy because we also have to ask them the history or sexual history, whether the patient is having some sexual disorder. See, unless you ask it, you will not be able to elicit it. And polytherapy is a very good option in such patients. And adding tadalafil 5 milligram at bedtime is a very good idea in such patients. It not only alleviates lower tract symptoms but also makes it better for him to perform. So both the things are addressed at the same time. And these medications and polytherapy works really well in such patients.
Completely fine with me. Dr. Taif, you want to answer the same question in your practice, in your way, or your thoughts on a 55 to 60-year-old man who requires a polypharmacy for LUTs, or these kind of therapy, for these kind of symptoms, and more which you have not discussed today?
The most important thing, as the age increases, the point of concern of the obstructive component being there comes into picture. So we have to keep in mind what are we giving for the obstructive component and balance it out with our medications for the storage symptoms, keeping in mind the side effect profile and the symptoms what the patient has come to us. So it has to be a balance between the symptoms, bothersomeness, and the issues at hand.
Fine, I've got it here. I would just change the profile a little bit and ask Dr. Gopal Krishnan. Gopal, would you be able to share a very short snippet of a case which was of a similar kind of overlapping symptom which you would not forget, your memorable patient, in very short before the seat belts are fastened for us to land?
I think a typical case is a relatively young man of say 46 or 47, comes with urge symptoms, has a very good uroflowmetry, and you often get foxed into treating him with only anticholinergics, but on closer investigation you actually find that he has got its classical middle lobe enlargement as you showed. So I think this is an important thing to keep in mind, that even relatively younger men may have obstructive symptoms, which are probably masked by their high detrusor tone and resulting in a very good uroflowmetry.
Awesome, Betul. Abhishek, you have a very small case in 3 sentences to tell me about a combination of this kind of a overlapping symptom.
Yes, just 1.5 months back, I had a 65-year-old retired teacher who presented with extremely bothersome storage symptoms of only 2 weeks duration. He says I was fine before 2 weeks, and then I developed this severe frequency, urgency, nocturia, and occasional urge incontinence. Only on eliciting, he says, yes, my stream was poor since last 5 years. And I asked whether any treatment taken. He said no. So basically, at this level, he appeared to be a case of chronic obstruction with detrusor overactivity secondary to it. But on examining, I find that there is a painless palpable bladder which remains palpable even after I ask him to void. So it got converted into a chronic retention. And I believe it was a case of chronic retention who was about to go into acute on chronic retention, and it was mimicking as a detrusor overactivity. Now, in the USG, I see that there is upper tract changes, the bladder is thickened, there is a 4 centimeter huge intravesical mountain like projection of prostate, and grade 3 prostate, grade 110 cc prostate with a diverticulum. So the bladder appeared to be quite difficult and probably underactive at this stage. So because it was a case of chronic retention, I advised a catheterization, and the post-void residue was 500 ml. I'm keeping it brief, so I'm skipping many points.
You need to keep only 2 sentences more.
So the interesting part was that in a chronic retention, I would give a bladder rest for at least 3 weeks before I would go for UDS, evaluate the bladder function, especially in this patient, and then decide the treatment. But here there were 2 questions before me. One was that I found the catheterization difficult because I found it difficult to negotiate across the prostate. Would I be able to do a UDS with 2 flimsy catheters? Would I be able to introduce it across this severely obstructed prostate? And if at all I do get a UDS done in it, and if it shows an underactive detrusor, would he be able to do a CIC 3 to 4 times a day? So then against all the guidelines, I decided to first leave the obstruction, explaining the patient that Yes, you may require a UDS later on and CISC2. So I do a stage 1 TURP, limit my resection because of slightly unhealthy urethra, and create a satisfactory channel. Post-operatively, on giving a trial without catheter, patient is happy. He says, "Doctor, thank you so much. I'm voiding so well. I don't remember voiding so well before." But then I see that the Qmax is only 10 to 12 ml per second, and there's a PVR of 180 ml. Right? Patient is saying, I am treated. I don't need any more treatment. But a PVR of 180 ml, and there was a bit of intravesical projection still left behind because I had to limit my resection time. So now, is that high PVR because of underactivity of the bladder, extremely thick, irregular bladder, not treated for such a severe obstruction since last 5 years? Or should I first do a stage 2 and remove all that obstruction that is still remaining, and then think of UDS? Now patient is saying, I am cured, I don't need any further treatment. But I was sure that he needs further treatment. I gave him heavy discount because price was an issue with him, and said I would do UDS for free. So eventually I did a stage 2 TRP. I was weighing between doing a UDS and then do a stage 2, or stage 2 followed by UDS. I did a stage 2 first, and I found that the post-operatively the PVR after stage 2 was just 20 ml.
I've taken it. I've taken the point. So, it's a Pandora's box that you opened up. Underactive detrusor, we are still grappling with it. A new term which came some time back and has been hidden under the carpet because we'll never be able to answer it.
Yes.
For a patient who is a diabetic, who is on catheter, multiple retentions and UTIs and epidermolysis, the balance between a patient understanding that he may not have a great flow, but maybe coming out of catheter is a known fact which we all do in our practice that the guidelines will never tell. So as we heard from you, friends, at this point in time, I'm attempting to bring about a close. And before I do that, few important words which Abhishek did talk about. The way we run our practices is about safety. We also look at patient concerns about a long-term therapy. Long-term is not in years, it's over decades. The cost of therapy is something which is borne by the patient itself. It's not borne by the medical insurance all the time. So I think when we look at the larger picture of prostatism, look at overactive bladder, both of them almost are entities which once hit you for all your life. That means you will either get a result, you will get a bothersomeness. The balance on the kind of a balancing scale is between you and your doctor, and that's what a urologist very much within the guidelines works around. We are proud today as Urology Society of India that we have our first guidelines which come up, which tells us about the cost factors that a literate urologist needs to know about. We need to know about an elderly man with his wife, with kids in the United States, or kids probably not around, with the cost that he has to spend around. So balancing all that you do on his bothersomeness, looking at the safety, the cost is important because they could jump the gun when the therapy looks good to them. Therefore, a medical management is all about a follow. And when I come to it, I can't forget about the era when we had those large capsules and we had those combi kits. And now we have 1/3 size from 18 millimeter capsule to 8 millimeter tablet, which is available as a combination therapy. We live in India, which is a country of innovations, competitions, and we know how to bend it like Beckham when it comes to these kind of situations. So when we look at the larger picture of treatment, we always understand that bothersomeness will continue to happen. In the era when we gave a very good therapy, which actually was a modest therapy with anticholinergics, which was very good at that point in time, the same thing has completely changed when Meera background came in, and as the world will change. We remember more patients with cognitive dysfunction. We did not at that point in time look at the cognitive dysfunction being a huge issue about anticholinergic burden. That's a big thing which we did not discuss today. But there's so much to talk on this. This subject will never end. It's time for many of our colleagues in the audience, my teachers in the audience, and people who have been commenting so much about it, that we draw this to a close. As we draw to a close, the excellent panelists who have taken their time out and agreed with one single phone call, I would leave them to give their last sentences on the kind of thinking out of the box with Alkem Urology took over and probably allowed it, the whole national team to come up around. So your last sentences on the plan, on the program, and your thanks and your respects to teachers in the audience. I'm starting with Kamal Chalani. Keep it short. We are closing down after all of you speak. Kamal, you. Kamal, your last sentences on the program and on your respect to teachers who have actually come to listen to you.
Yeah, thanks to Alkem Urology, Urocare, that they gave me opportunity to be panelist on this forum. And I would say I would pay my regards to my teachers who might be listening me, and seniors who might be listening me, and to the colleagues and to all the people who joined us. And I hope they must have enjoyed this power-packed discussion, which was moderated by a powerful person like Dr. Sanjay Pandey. So I would say thank to everybody.
Abhishek, your last sentence, please.
Yes, sir. This kind of Arnab Goswami kind of discussion was really interesting, and I have no hard feelings for those who I countered. But yeah, it was really fun, and I would wish that we have more and more discussions like this with you, sir.
I enjoyed listening to you, and your take-home point. The last case was very interesting. We all do it in our own way. We look at safety of patients around.
Yes.
Dr. Taif, thank you so much for having agreed in a very short notice. Your last comments on a wonderful way you took the cases with safety.
I want to thank you for this opportunity. Wonderful program, wonderful initiative, beautifully conducted, and my respects and regards to all the seniors and teachers who are watching us. And like you have highlighted, though our viewpoints may differ, but our perspective has always been the patient safety first. So that is what will be our prerogative.
Well said. We may differ, but we all look at the same goal. We look at how patients improve completely. Friends, before the two senior people come in to talk around, I would say that we have the next session on different set of cases on 10th of September, and it will be great for you to join in. There are 3 slots of the 5 slots vacant. So if anybody is keen to actually come on a question and answer session, we'll be very happy to have you in. Dr. Bole, your last comments on a wonderful program. Thank you so much for being there.
Thank you so much for making me a part of this wonderful program. I really enjoyed the topic of it, the overlapping symptoms. We went into real basics, and we are what our teachers have taught us today.
Absolutely.
We are here, and that is why I always stress the fact that we start from the very basic. Technology, it may advance to any level, but if we omit the basics which our teachers have taught us, we will not be good in our art. So thank you so much for all this, and I really thank my teachers because of whom I'm here today, and I will continue to thank you all my life. Thank you so much.
Awesome, Dr. Bole. Thank you so much. Dr. Gopal, your last sentences before we come to a close.
Yeah, I think we all understand that prosthetic treatment is a functional treatment and not an anatomical treatment like a nephrectomy or a partial nephrectomy. So I think here the treatment often it revolves around patient-centric and common sense approach. Here I think what our teachers have told us to read between the lines, look at the patient, I think that is what we need to follow. As long as the patient is not in danger of going into retention or UTI or upper tract obstruction or renal failure, I think the treatment is basically patient-centric.
True.
Absolutely. Absolutely. So thank you, wonderful panelists. Thank you, teachers. Thank you, friends. You all have actually done wonders to stick around on this Friday evening with us. The program was to probably just excite more discussions. There's so much about it. Why is dutasteride taken every day instead of taking it alternate days, like 30% Americans are treated around with that? Why do we have to give a combination of only finasteride with the older drugs, and why finasteride has not come with the newer alpha blockers? When is Meera Bagron going to join hands and becoming a partner with Silodosin as a single tablet or capsule? A lot of things will come in future. As future comes in, as we meet again on 10th of September. Thank you, all of you. It's time to land and rest yourself. We have just delayed you for the dinner. Okay. Have a great weekend, and we'll get back again. Okay. Thank you, friends.
Thank you so much.
Thank you. Thank you. Thank you, Alkem Urology. Thank you so much. Thank you, Ankit. Thank you so much, Alkem. Very well done. Very well thought of, yes. Very well programmed, and very well conducted. Thank you again. We'll come back again on 10th of September. Okay. Thank you, Kamal, Dr. Taif, Abhishek, everybody. Thank you so much.
Okay, thank you so much.
Thank you.
Really enjoyed it. Good. All the best. We close down and take a break now. Bye.
Bye. Bye. Bye, everyone.
Thank you.
Thank you all the panelists.
Okay, sir, should I show?